today and not tomorrow, when it's wear your workout clothes to work all day. So we're glad you're all here to hear the release of the CHAZ report. We're happy to be funders of the Colorado Health Access Survey. And I was, a little depressed when I first read the title. I was hoping it would be flipped, like progress, kicks Peril's butt, or something like that. But it didn't turn out that way. So that just is a reminder to all of us how ever and forever vigilant we have to be in the work that we do on behalf of children and families and communities, because we have to work hard just to keep the status quo going. So I'm excited to hear this report, and more excited about what it means for how we're all going to work together over the next 2 years to eviscerate this title. So I'm going to hand it over to Michelle Look right now.
Into the differences that we see between 2017 and 2019. So I'm going to share those with you, share some of our thinking around that today. So I had a boss at one time who said, Michelle, never spill your candy in the lobby, which means, you don't sort of lead with your big punchlines first. I'm going to disavow that advice and share with you exactly the 5 things, there are 6 things that we'd like you to take away from this presentation today. First of all, in terms of coverage, this is always sort of the big story of the CHAZ. There's no change on the surface, but those still waters run deep with the turbulence and turmoil that I'll share in just a minute. We've asked some new questions this year on food, housing, and health, and the economic boom that that we've seen here in Colorado, where we hear about all these college graduates moving into Denver and living along the I-25 corridor and taking over all the apartments and clogging up the freeways and the highways, that boom is really unbalanced. We're going to take a look at how it's impacting some more than others, and it's leaving a lot of us here in the state behind. The third thing is that we've asked people specifically about, have you ever been treated unfairly in the healthcare system? And a lot of people told us that they have. And I'm going to share a little bit about who they are and why they think that. We are seeing an uptick in the usage of care, but with one major exception, and that exception is behavioral health, where we're seeing greater awareness about issues and problems in ourselves, in our families, and in our communities, but still having trouble getting access. If you change your methods, it's a little hard to know if you're going to be able to trend that data. So we did a little sampling of the phone, on the phone, enough to know that what we were seeing in this new methods actually was trendable data. So we're very confident that the years between 2015, 2017, 2019, it's all possible to do. This is not an insignificant undertaking. We have 3 FTE who work on this just about all year long. There's a lot of intensity around cognitive testing and survey development and figuring out what we're going to ask and who we're going to ask that of. And we couldn't do that without the partnership and the support of both the Colorado Health Foundation and the Colorado Trust. I also want to thank my friends at HCPF, as represented in the front row, notice they aren't in the front row. They're stewards of the CHAZ. I want to thank them and the Office of Behavioral Health. Anyone from the Office of Behavioral Health here? All right, so they're also sort of financially supported the survey this year. So what I ask of you today is, can you show of hands if you have a smartphone on you with a camera on it? Okay, so can you take those out? And the thing I'd like you to do is take a picture documenting this moment in time. And I don't want everyone taking a picture of me. In fact, I want no one taking a picture of me. And so would you turn around and take a picture of like the beautiful scenery, or Karen sitting in the back row, or your neighbor, or your manicure, pedicure that you got this weekend, something that documents this. Your BFF, who you brought. All right, does everyone have a photo on there? Okay, save that photo because you're going to do something with it a little bit later in the presentation. But your photo documenting this moment is just like the CHAZ. We have taken a picture of what the Colorado State looks like in 2019 in terms of all those different areas that I've just shared with you, access and utilization and so on. Okay? But what I want to stress by that is that we also took a picture in 2017, but we don't know when the picture is different between the two, like I've aged 2 years or something like that, right? We don't know why that is. Well, aging you do, but say I got really fit and ran a triathlon or something like that. You don't know what happened in between those 2 years to look at the difference in the picture that you're seeing. So we're asking you to help us sort of put that picture together today. So what are the policy developments that have contributed to the changes that we see? Has it had something to do with Medicaid expansion? Has it done with some implementation or some retraction of the Affordable Care Act? What has happened in our daily lives or our policy lives that have made a difference in the changes that we see? And what do these suggest about further policy issues? And I'm going to come back and ask you this at the end of my presentation here. So I'm going to move right into the stories. And when I say that it's hot off the press, it also means it's the first time I've delivered this. So bear with me if I look at my notes a little bit. So change runs deep. There's no change on the surface, but still waters run deep, and those waters are turbulent and tumultuous. So what do I mean by that? This is what our uninsured rate looks like overall. If we take a picture of the whole state of Colorado and leave it at that sort of state-based level, and if we move from 2017 to 2019, we see virtually no change in our rate of uninsurance. This is a little surprising, right? Because we hear and read all the time about the erosion of the Affordable Care Act and the sort of dismantling of that at the federal level. So kudos to everyone in Colorado who's fighting the good fight to keep that uninsured rate up. And a lot of us in this room who represent advocacy organizations, outreach organizations, provider organizations are doing our best to keep people enrolled in health insurance. So the person that you just took a picture of, give them a pat on the back. Come on. So what does this mean in terms of how we're getting our health insurance? And so this is like everyone in Colorado, 2009 to 2019, every other year. This adds up to 100 over here. How do people get their health insurance? And so the first thing I'm going to put up is how people get the rate of people who are uninsured. We had high levels of uninsurance before the Affordable Care Act, and we've whittled that way down from near 16% here in 2011 down to just 6% this year. The second thing I want to point out is around people who get their health insurance through their employer. And in 2017, it was sort of a bellwether year for us because we dipped under the 50% mark. Less than half of us were getting health insurance through our employer. Now, part of the economic boom that's happening is that we've seen that shift above 52%, right? So something like 100,000 people are moving to Colorado each and every year. They're living along the I-25 corridor. They tend to be graduates from college, and they're finding jobs. And so we think that this has something to do with this uptick in employment-based insurance. Does that make sense to you? The individual market is sort of holding steady right around this 18, 19%, and so those are people who buy primarily on the health insurance exchange, and we're lucky that in the state of Colorado that that's a live and vibrant infrastructure, and we've seen that sort of level off. Other insurance, and then the last thing I want to point out, oh, I'm sorry, did I get that wrong? Where's my Medicaid on here? Oh, the dark blue. Yep, okay, hold on. I got that wrong. So this is Medicaid here, the dark blue here. And we've seen a tiny decrease in Medicaid enrollment. So a couple of things might be happening here. One of them might be that the economic boom is hitting and people are getting paid more money and rotating off of Medicaid insurance onto employer-based insurance. It could also be some sort of less inspiring news about people losing coverage or deciding not to enroll in Medicaid, and I'll get into that in just a minute with some of the policies, say, around immigration. And the last thing here is Medicare that I want to point out. We're holding steady right around 14% of us are qualifying for Medicare. So as this is, when we look at uninsurance or insurance rates and the rate of uninsured, this is probably not surprising. The darker the purple, the more people who are uninsured in those particular regions. What's happened up in that region in the last few years? Where was the idea of reinsurance born? Where was the option? Where was the idea of the public exchange born? Where was peak health born, right? It's born in this region that's really dark purple. These are sort of market and public reactions to a problem that those Coloradans in particular are facing the hardest, right? And so it makes sense that Chris Kennedy and Julie McCluskey and other legislators have paid a lot of attention to that. And so that's the genesis of a lot of our health policy innovations, really, in the last couple of years. I want to look at this. We can slice and dice this data in a variety of ways. I'm going to look at a few different cuts of the uninsured because it's so important to getting right care at the right time and all of those kinds of things. So this is stratified by age group. So the new news here this year are a couple of things. First of all, what did we used to call this 19 to 29-year-old group? Young Invincibles. And they're less invincible, or they don't feel that way as much as the 30-year-olds. The 30s and 40-year-olds actually have a higher rate of uninsurance than the Young Invincibles do now. So you think about that and you think, well, why might that be the case? This is our snapshot in time. So we've seen this sort of, the 30 to 49-year-olds are leading the pack in terms of uninsurance rates. It may be that the 19 to 29-year-olds, does anybody have a kid in that age group? Yeah, and do you know that they can be on your health insurance now up until the age of 26, right? So we speculate that it's taken a little while from the enactment of the Affordable Care Act to sort of full implementation of the Affordable Care Act, right? So when you have 19 to 29-year-olds, it's only your 27, 28, and 29-year-olds who are not sort of part of the youth movement anymore, right? And so they can't be covered under their parents' insurance. And so we think that that may have some impact on why we see this shift happening. The other thing I want to point out, and this is a headline story, it'll be on 9 News and a few other places later today, is this 4.3% of kids. And so in the 0 to 18, we've seen this uptick in the uninsured rate. And you guys, this was like our, it was a heralded moment 2 years ago because we had such a low uninsured rate among kids. We were down under 3%. And we've done a little deeper dive into this 4.3% and parsed it out in a couple of different ways. The most significantly impacted subpopulation of the 0 to 18 years old is the Hispanic population. If we look at the non-Hispanic population, the uninsured rate actually improved. It went down a little bit. But with the Hispanic population, it more than tripled in terms of the number of kids that no longer have health insurance, and it's up to about 53,000 kids who are identified as Hispanic or Latino on the survey. So this is like one of the canaries in the coal mine that I mentioned, right? What is happening there? We don't know exactly, but who has an idea? Immigration policy, right? And so we're hearing that anecdotally. People representing safety net clinics here today? Anybody? Yeah, Phyllis. And so what are you seeing there?
We are seeing families come in and say to us, we're not coming back.
Right.
We cannot come back. We can't have our names on anything. We are not coming back. We will go to the emergency room if necessary.
Right, right. And so we're seeing this anecdotally in just the providers that Phyllis represents, that we're seeing an increase if they do come in their uninsured status and decrease in Medicaid. The public option, which is due to take effect on October 15th, not the public option, public charge. The new thing about the public charge is it's including Medicaid as one of the programs that it looks at in terms of how are you reaping services. And we speculate that in these families where they're sort of mixed status families in terms of insurance, those parents who most likely are non-citizens or don't have documentation, and their kids are citizens or are born here, we suspect that they're keeping everyone out of the system for just the reasons that Phyllis articulated. So that's a big warning sign to all of us, and something that we should think about how we might mitigate. And your third question about how we have come up with options moving forward, right? The rate among the population who identifies themselves as being Hispanic or Latino, we've seen this sort of settling off around 10% of the population. It's still about twice what it is for the non-Hispanic white population. That hovers around 5.5%. And so even though we've seen some dramatic decreases in this relative to other populations, it's still a concern, I think, and potentially a focus of future policy work. We do ask a question about citizenship on those chats. And we don't ask about documentation, but we do ask this question as if, are you a citizen? Yes, no, on it. And you can see that there's a really large difference between citizens and non-citizens in terms of how they report on their uninsured status. So again, sobering as we look just under the surface of the 6.5%. And finally, looking at the poverty level and looking at the uninsured rate, pay attention to these red bars on your screen here. In the days before the Affordable Care Act, Medicaid, this at or below 100%, or in the 100 and 200% where it had the highest rates of uninsurance. We've seen that taper off. Those individuals and families have been absorbed and enrolled into Medicaid, but we see a tick up here at 200 to 300%. Any ideas why? Yeah.
Subsidies at that level are lower and
Right.
will stay up.
Right. Yeah, Phyllis?
Subsidies for independent insurance are in that 200 to 300% range. However, even with that subsidy, it will cost a family the price of a car to be able to afford health insurance.
Right. Right. And
And-
Phyllis has a documentation to back that up. She showed me earlier.
And now there is no requirement to be insured.
Yes. Good point. You have something Right, right. And so we think that this group is really price sensitive to health insurance. And so when they fade off of Medicaid or they fade off of CHIP and like, hello, you've got to pay for your own health insurance, this part about it's a car or it's your health insurance, those are really impacting this population right here. It's probably the most price sensitive population given the change in subsidies and who's covered under Medicaid or Medicare. So we thought that was pretty interesting this year. This is another sort of canary in the coal mine. We look at this question of churn and we ask, have you lost or gained or changed or transitioned between insurance products in the last 12 months? And when we look at just everyone who's not in Medicare, because Medicare, you kind of go on Medicare and stay on Medicare forever, but if you're not on Medicare, if you're under 65, 1 in 5 of us is changing over this 12-month period. And we have some concerns about that because of continuity of care, right? And so we want people sort of staying on the same health plan with their same providers. It's also an indication of maybe market instability, right? And so people are going to the lowest cost provider or some other kinds of choices that they're making. And it could also be, I think, maybe an indication that the exchange is kind of doing its job, right? And so each year you go and you look on the exchange and you find the product, the insurance product that's going to best meet your needs at the price you can want to pay, right? But I do think that we've seen this trend up from 12% in 2013. Now we're up close to 20%. So this is telling us something about this market. And we want to unpack exactly what it's telling us over the course of the next few months when we dig into this data a little bit deeper. Food, housing, and health. And this is where we sort of look into questions of is this economic upswing impacting us all the same way? And the CHAZ is telling us it's really not. And the first way is that 18% of us report having trouble paying their medical bills. So again, that's 1 in 5. We have 10%, so 1 in 10 Coloradans are telling us that they don't have access to healthy foods and or they're not eating as much as they think that they should be eating because they don't have enough money to do that. And we estimate that housing instability, so people who feel like their housing has been jeopardized in the last couple of months, just at 6.5% as well. This is a map looking at this one specific question. Respondents who ever ate less than they felt they should because there wasn't enough money for food in 2019, right? So the darker blue is somewhere between 14 and 20% of people in those regions are saying we didn't eat enough because we didn't have money for it. Any impressions about this? Any reactions to this?
I would just say I think that it's really good that you're showing this map rather than one percentage for the entire state, because there really is a significant difference of food insecurity in different communities across the state. We're not a good place on the issue.
Right.
And so I'm happy to see you displaying the rates across the state.
Great. Thanks, Elizabeth.
I also think that this is the data of the people that you actually survey.
Yes.
So in my work that I do in community, I believe that that is truly not reflective of many communities. I think it's much higher as far as housing instability and ethnic insecurity.
Yes. So there might be some reticence to share exactly how you are because this is self-reported data,
Plus,
right?
they didn't want to stay on the phone for 22 minutes.
Right, right. All these people,
No, I mean
yeah.
the other people who that maybe or didn't
Yes,
want to.
yeah, yeah. So we do some balancing to make sure that it's weighted and representative, but I understand your point about this maybe under-reporting of these issues. Yeah, Phyllis.
One of the things that strikes me about it is the darkest areas are very much farm country. So what does that say?
Right. One of the things it could say is where are the state's sort of, where are the most disadvantaged people, where do they live? And if we look at the rural-urban split on this, 24% of people in rural Colorado live below the poverty line, 24%. When you look at the urban core here in Denver, that number is much lower, it's like 17%, right? So there's a 5-6% difference between those two populations. So the people on the plains or in the southwest corner in these rural populations have a higher percentage of those in living under the poverty line, right? It may also say something about support systems, right? So we have Project Angel Heart, and we have all sorts of human supports to get food pantries in Centennial and the Denver Rescue Mission and places that are really well established to get food to people in the urban core. I don't know, it would be worth researching whether or not that sort of extends out into the rural areas. Yeah,
Project Angel Heart, we're about to start a pilot in the southeast part of the state.
bless your heart. Thank you.
This is really cool. Yeah.
Great, okay. So give your cereal boxes to Project Angel Heart. They're going to this area, right? We sent you a bunch of cereal boxes?
Yeah.
Okay, great. Unfair treatment, this is sort of a new question for us, and we've classified this as a wake-up call. When we think about issues of discrimination, when we think about issues of equity, how are we doing even within our own healthcare system? So we asked people, have you been treated unfairly when you got medical care? Have you been treated unfairly when you get medical care? And 60% of us said never, it's not a problem for us. But that leaves 40% where it's something else than that. It's either rarely, sometimes, or often. And this corner down here, we're very concerned about where it's sometimes or often, and that's 15% of the population. When we look at those, any ideas about what are the issues that surface the most in terms of being treated unfairly? Yes, but not the leading one. Age, gender. Those are the top two, and this is the first time I've given this, so I have to look for the third. Age, gender, disability. So whoever said that got it just right. Okay. So we were looking to unpack this over the course of the next few months when we were able to have the time and the latitude to dive a little deeper into this. That this is a very interesting question, we think, at the Colorado Health Institute in terms of what can we learn about the system as it is. Use of care. Again, this is, we ask people how often they go see a provider, both a physical health provider, mental health provider, or both, and these are the results. And interestingly, in 2019, more people are going to the doctor, and more people, as a percentage of the population, are going to the doctor and seeing the dentist. So this slide is, I think, a little, it can't be misleading. So if you look at that general doctor, it went from 70% of people said they went and saw a doctor to 80% of people in a 2-year time period. So I did a little back of the envelope math, and that's a lot of people. That's about that's 500,000 people, just over 500,000 people went, that delta between the two is another 500,000 people going to see a doctor, right? So that's a big jump up. We also asked whether or not they saw a general doctor about mental health issues. And again, these numbers up by 2% may not seem like enough, but that's 110,000 more people going to talking to their general doctor about mental health issues. And the same thing here, that you actually went and saw a mental health provider. We estimate that over 110,000 people made that visit in 2019 compared to 2017. These are some big jumps in utilization, and we contrast that with this sort of sobering news on behavioral health. And so remember that there was a lot more behavioral health visits, probably on the magnitude of 200 to 250,000 more people either talked to their own doctor about mental health issues or they talked to a mental health provider. But when you ask about mental health overall, this almost seems contrary to what we just learned. And I'm going to ask you why it may not be contrary. So we asked people, did you need, did you not get mental health services when you needed mental health services? So you know you needed them in the past year, but you didn't get them. And we see this number go up. From 2017, 7.6% of the population said that they didn't go get the mental health services they needed. And that spikes, it nearly doubles in 2019 to 14%. So we have more people going for mental health visits, and we have more people saying that they needed them but didn't get them. So how could that be? Awareness, we said awareness. All right, tell me more.
I think it's more common talk you see on social media, everyone's talking about the traffic that used to come with it. I mean, it's just not
Right.
surface now, and so people are more apt to go ahead and make that appointment and do that.
Great, great. Anything to add to that? So we also asked again about substance use disorder treatment. This is a relatively new question for us. It only goes back to 2 years. But again, we see this uptick in the people who are reporting that they needed that service but didn't get it. If you look, I messed up the punchline here, so apologies. If you look at this 2.3% number, again, doesn't seem very big, but it's approximately the size of the town of Longmont, or the city of Longmont, right? So there's 95,000 people live in Longmont. 2.3% of the population is 95,000 people, right? So it's not an insignificant number of people. They're saying that they needed substance use disorder treatment and didn't receive it in 2019. So I think our work is cut out for us there. We asked them why they didn't get mental health services. If they asked that question, if they responded in that way that they needed it and didn't get it. I want you to look at the top and the bottom of these. For those who needed mental health services, cost is stratified at the top, cost of treatment, and didn't think insurance would cover it. Then you look at the the second and third places, another third, 30 to 40%, said that these are really issues around stigma, right? They didn't want other people to know about it. They didn't want someone finding out you had a problem, didn't want to talk about personal problems. So that's interesting to us. And again, we want to spend some time dissecting what this means. And then we did the same thing. We did the same sort of scores for substance use disorder treatment. And you see sort of a similar stratification where cost, I think we did better on cost, but it's still a cost issue, as well as the stigma issue seems to be really significant on that as well, right? 3 out of 4 people are telling us that they didn't get substance use disorder treatment because of the stigma associated with that. New to the CHAS this year is, I think, has implications for sort of those of us who think about sort of social movements or community action of one sort or another. We asked, have you, a loved one, or a close friend ever been addicted to prescription prescription painkillers or heroin? That comes in at 12%. Been addicted to alcohol or drugs other than prescription painkillers or heroin? That comes in at 25%. We asked some other questions down here, but I think of this as being, what's the tipping point when we're all so closely impacted by someone who's succumbed or been has been disadvantaged by opioid addiction, painkiller addiction, alcoholism? When does it become? When does that sort of tipping point occur where it becomes just national priority with a lot of national urgency?
And I would just say, sorry,
Yeah.
I just think it's really important to highlight the 25% there with the alcohol, because there's been so much focus on opioids, and
asked this question for the first time on the survey, is opioid addiction a major problem in your community? The darker the purple, the more people said, yes, it's a major problem in our community. What's most interesting, maybe what's not on this graph, 50% of respondents said they didn't know if it was an issue in their community. So that half of us are unaware yet of whether or not this is a major, minor, or no problem at all. That's sort of the stratification of the questions, right? So you think about these tipping point issues and what we need to do in terms of developing political will, and the work that we do at the community organizing level may be particularly important when we look at this issue. Comments or questions? So finally, I want to share a little bit of affordability with you. Warning signs that we're backsliding, that we're not addressing affordability as quickly and as aggressively as perhaps we should. Problems reporting medical bills, we went over that before. Of everyone who's still uninsured, that's 6.5% of all Coloradans. 90% say it's because they can't afford, that the cost is just too high, and that's the reason that they're not covered, right? Another way of looking at this, isn't that cute? Brian Clark, those who know Brian. Surprise medical billing. 1 out of 3 of us this year has had a surprise medical bill. 1 out of 3 of us this year. I just find that interesting and cautionary. So the big stories here, again, just to recap, if that chocolate chip cookie sent you off into a wee bit of a slumber, there's no change on the surface. We're holding steady at 6.5%, but there are issues that I think are sort of canaries in the coal mine for us. The economic boom is really unbalanced. We're seeing a lot of people become more and more affluent, but there are people who are being left behind, can't pay their medical bills, have issues with housing and food insecurity. We're waking up to the fact that we have unfair treatment in the health system. I think the policy question is, what can we continue to do about that? We're seeing an upswing in terms of utilization. The question is that a good thing or a bad thing? We saw a slight decrease in terms of preventive visits, increase in specialist visits. Is that the trend line that we want to continue down? We've seen behavioral health with this sort of weird teeter-totter of more people getting into seeing either their primary care doctor or their mental health provider, but we see an increase in demand as well. So are we really balancing the scales there? And I think that there are underlying issues that I tend to think that the very aggressive, not very aggressive, but the progressive policies of the Polis administration around reinsurance, public option, offices saving people money on healthcare, looking at ways in which we can buy prescription drugs from Canada, that is not coming out of nowhere. This is a direct response to the way Coloradans are feeling about how unaffordable healthcare continues to be in our state. So, last thing before oh no, what happened? Can you go back to my slide, what happened here? Did I do it? Oh, okay. You have to go through it all again, Jasmine.
Yes.
Okay, hold on. This is the fun part. Yes, the review. Oh. Better not go too fast now. All right. I'm finally back. Remember that photo that you took, right? So it happens to be the 10th birthday of the Chaz, and so we've been doing this for 10 years. I'd like you to take your phones back out and tweet to hashtag Chaz19, right, Becca? Hashtag Chaz19, either a birthday wish or a thought you have about the Chaz. You can do that now. I'll give you 1 minute. So we're having a contest at CHI about who gets the most social media attention during their Chaz presentation. I'm lying. But we appreciate you putting it out there on Twitter for us about the birthday and the unveiling of the Chaz. We invite you to sign up now for our conference on December 5th and 6th, our annual Hot Issues in Health Conference. We'll dive into Chaz in a number of different ways. Our annual meeting this year will end, our closing session will be a deeper dive into many of these issues and more. It will be hosted by my partners in crime, Jeff Bontrager and Eli Boone, who have done all the legwork on this presentation, so I want to take a moment to thank them for that. And I hope that you join me there. Who has my first question or comment?
Nice graphic on the surprise medical bill, right? So I think something that's been just kind of coming to mind when we talk about things like surprise medical bills, I think the public's understanding of that is very different than the policy community, right? When we talk about
Yes.
legislature and Congress or at state level about surprise medical bills, we're talking about a really discrete, like when you go to a hospital, but there's an out-of-network doctor. Whereas I think the number might be so high there because
Right.
people are saying, well, I went to the doctor and my insurance said it's covered, but I still owe a lot of money.
Yeah.
Right, which is more of a high deductible health plan and insurance, a health literacy and insurance education
Yes.
kind of question. So I don't know if there's any more behind that, but more of a comment.
Right. Your comment is well taken. It's similar to the comment we heard earlier about housing and food. It's a limitation of the methods of the survey, right? And so we're asking people to self-report on everything that's in the survey, including surprise billing. And so it's like you open it up and it's like, oh my gosh, that x-ray costs $250, surprise, and that's not exactly what you meant by surprise billing. So we understand that, and I think it's important, I think, at least in our language, to dissect that out. So thank you for the point.
So you mean like an incident that was outside of the expected care?
Yeah, so we ask respondents to say, have you been surprised by a medical bill in the last 12 months? And so we don't go into the technical policy description of a surprise bill is when, you know, most of your bills come from in-network and one comes from out-of-network and it's higher, like whatever you would say that is, right? And so we're really leaving it up to the determination of the respondent to sort of say, to identify what a surprise bill is. On many of our questions, we do a lot of cognitive testing, and so that we know, like when they're reporting on, when they have Medicaid, they may not understand that they have Medicaid, or Medicare is a perfect example when they think that they have Anthem when they really have a Medicare Advantage plan. And so we've learned how to whittle down, and so that the answer that we're getting is actually representative of the kind of health insurance that they're getting. But I think in some of these questions, it might be a little harder to parse that out. Yeah?
Among uninsured and then even long-term uninsured, is there ability in the data to parse out who's tried to earn insurance during the last year?
Who's tried to get
Tried to
insurance?
get it, whether there's maybe resigned themselves to not being able to get insurance at all.
Right, right. We do ask a series of questions. I'm looking for my lifelines in the room. Those would be Jasmine and Becca. We do ask a series of questions. If you don't have health insurance, why is that? And there's a list of like 10 different reasons. And do you guys have anything to add? Like in terms of, is there a reason that's like, I've looked and I just can't find anything?
We don't have a reason for that per se, but like we have things like you don't know how to get insurance or you don't think you need it, those types of things, but not questions about how they tried to get care, where that ended.
Yeah.
For the question around people reporting opioids as a major concern, I'm just wondering how is that? I'm thinking as a respondent, how I would answer that, like in terms of how would I quantify whether something's a major concern? Like assuming that people around me are using opioids. I'm just wondering like what the actual questions were to get at.
Right.
How you define major concern? Is it like I know that a lot of people are using opioids. I know we have a lot of opioid deaths in our community. Like
Right,
I
right,
can see it being very perception based and
right.
hard to get at.
Yeah, so I think the intention is a perception-based one in that. So we asked to, we can look at the exact wording of the question, but it's, do you perceive the opioid crisis or, opioids as being a major, minor, or no problem, right? So you have a choice of questions to answer. I'm looking for validation of that. And then, but it is like sort of in the mind of the consumer, right? In the mind of the community member, is this a pressing issue or not? And so again, we haven't defined, a major problem is when more than 2% of your, population overdoses. We leave that into sort of the mind's eye of the consumer or the respondent in the survey. Right? Yeah.
For the 15% that have lost or changed coverage in the last year, do you
Yeah.
have a sense of if that's because individuals are shifting eligibility, like moving from Medicaid to the exchange to employer-based
Right.
insurance, or if they're switching plans within the exchange or switching jobs?
Right. We don't today, but we will in December. So sign up today because that's something we really want to look into. We just haven't had the time to do that since we got the results back. Yeah, Phyllis.
So, two comments and a question. The first comment is, really appreciate you guys being able to dig in as deeply as you did
Great.
in a
Thank
short
you.
period of time.
Yeah.
It's really just awesome to see. The second is, for those that are college age, that group that we're talking about, in addition to being on parents' insurance, there is a requirement by college that you have insurance. So even if you're not on your parents' insurance,
Right.
there is a lot of effort to get them covered.
Right.
They can be covered by Medicaid in certain circumstances.
Right.
But most people don't know that. So
Yeah.
that's an important policy thing, I think, for people to get out there, for
Yeah.
folks who don't have insurance.
Right.
for their family.
So listen to Phyllis as a mom of 2 kids in college. There are multiple ways for me to pay for their health insurance. So thank you.
Yes.
Yeah.
And then the
Oh.
question that I had was, this affordability issue, we have tried to look at it within our own group of safety net clinics.
Right.
Because some clinics do serve only uninsured and some clinics serve uninsured and Medicaid.
Yeah.
They don't cross over right now. But we'd love to dig in more with you because we're not sure it's a public charge issue entirely.
Right.
We think it's a bigger issue, but in order to address it, I think we need more information from you guys on what we're looking at.
Fair enough. Give us a call. Thank you. Yeah.
Yeah, I have two questions on the mental health data.
Yeah.
First one is, that series of questions about who or someone you know who has an opioid addiction, alcohol addiction, are those new questions? Or do you have older data to compare it to?
Yeah, they're new this year, right? 'Cause that's why they're not trended.
They look
Yeah.
new, so it'd be
Yeah.
interesting to see how that changes over time.
Yeah.
The second question was about that big strong uptick in the unmet need in behavioral health.
Yeah.
Needed care for them to get it. Since it's such a large jump, do you think it could be something to do with your serving at this time that are different?
Yeah, we can't say decisively that it doesn't have to do with that. I mean, I think that we can may be able to look at that in a few different ways to make sure that we're confident in that But you're right that, it's almost doubling in the number of people. And so is there less inhibition, getting back to this question about food security and housing, is there less inhibition when you're filling it out online versus talking to someone on the phone, right? And so those are things that we will want to consider in future analyses and potentially do some research around the methods. I think that's a good point. Yeah.
With the new survey method, the
Yeah.
scenario, I was looking at the data that you were referring to, 6.7 housing insecurity, it really felt low to me.
Yes.
And since, a lot of people experiencing homelessness obviously don't have an address that you can send the survey
Right.
notification to, is there a way that you all contact people experiencing homelessness?
No. I'm looking at the back. So that is, we've done a lot of things in terms of making sure that the survey is representative of income, but I think this housing issue may be one that is potentially compromised by that as a limitation of the survey. So, final question.
At CCLG, we've been looking at Medicaid enrollment, and our numbers on Medicaid changes between 17 and 19 are steeper than I think what's reflected here
Yes.
by a pretty big factor.
Right.
So I'm curious about what that, your explanation for that might be, or maybe it's, partly population who don't have stable housing, or
Right.
Families that have mixed status, maybe some members who don't have documentation aren't answering at the same levels. I'm not sure.
Right. So I think your point is really well taken because the administrative data from Medicaid has shown a larger drop-off, right, in terms of Medicaid enrollees. So there may be a few things going on here, and I think we'll go back and take a look at that in more depth in the coming months. It's a retrospective survey of the previous 12 months, right? And so there could be some timing issues with that if the decline happened fairly quickly. But that's something that we can certainly follow up on. Makes sense. All right, with that, I want to thank you for your time and your engagement here today. I'm here for the next hour before we do this all again at 4 o'clock, so stick around, and if you have more questions or have additional comments, I'd love to hear them. Thank you.
Director here at the Colorado Health Foundation. Unfortunately, Karen McNeil Miller, our CEO, couldn't be here to kind of kick this off. She was sad to not be here. So you get me. I'm really excited. The CHAS has been a big part of the work that I have focused on at the foundation over my 12 years here in the areas of primary care and behavioral health. So I get really jazzed when we have the kickoff of the CHAS, when the data comes out. So I'm privileged to kind of welcome you here to the Colorado Health Foundation. We have been funders and co-funders to informing policy and all the great work that I know many of you are doing in the field around health coverage and health care. So, I would be remiss if I didn't kind of echo what Karen kicked off the 2 o'clock session, and that the title is daunting. We hope that we can continue to see progress, and yet I think it's important for us to look critically at the data and think about, okay, what do we do with it, and what needs to shift in our programming and in our policy to continue to push the needle on coverage and care in the state of Colorado. So with that, I'll hand it over to Michelle, who's going to take us to the next level.
Great. Good afternoon. Thanks. It's really nice to see so many people here, and familiar faces and some new faces. And my name is Michelle Leek. I'm the president of the Colorado Health Institute. We've been doing this for 10 years, and I have been lucky enough to be a part of 8 of those 10 years at CHI and with the CHAS. So I will start right off, and I want to thank you again for coming on, is it the world's most beautiful day outside right now, 4 o'clock in the afternoon? So let's get going. Progress and Peril is what we've titled the release of the CHAS this year. And I think it sort of underscores the point that we seem to be doing pretty well in terms of holding our own, in terms of our uninsured rate and keeping people insured here in the state of Colorado, which was a little bit of a surprise to us. But there's a lot of things right under the surface that give us our sort of warning signs around affordability, around churn, around the story is not the same for all populations. And so I'm going to spend a few minutes sharing with you some of those findings. So this all comes in the context of a lot of things that are happening in health and health policy, particularly under the Golden Dome. We release this survey and conduct this survey every other year. And so since 2017, there's been a lot of changes, right? It's been a lot of changes in terms of our economic expansion, at least here in the state, has continued. We have a new governor. We have a Democratic-led Senate, House, and executive branch, which has led to some pretty progressive policies. And so if we look at the health policy agenda of the last year at the legislature, a lot of things happened, right? Reinsurance, public option, transparency in hospital pricing, surprise billing mitigation. What else has happened? Prescription drugs. The list goes on, right? And so we did a lot of work in terms of health policy. So that's what's happening at the state level. And of course, at the national level, you can't go a day without hearing the news about a Democratic primary candidate speaking about health care in one way, shape, or form. And we have a lot of activity, I think, coming out of the current administration, right? A lot of steps to reduce the impact or repeal parts and pieces of the Affordable Care Act. That's sort of the context in which we all live. And it's within that context that we share the results of the stories, because a lot of our findings are the result of or a reflection of that larger market. So I'm going to dive right into the top line of what these stories are. Then I'll back up and share a little bit of the detail around these storylines. The first, we have 6 stories to share with you, 6 headlines, so to speak. And the first one is that there's no change on the surface when it comes to our uninsured rate or our coverage, but the waters run deep. And those waters are filled with churn and turmoil and turbulence. So we may see a leveling effect on our uninsured rate, but we think that there's significant noise and turbulence right under there. Food, housing, and health. We have some questions on the CHAS this year that look at issues that are in the adjacent fields to healthcare delivery. And food, housing, and health tell us that this economic boom that we are experiencing here in the state is not equally shared by all people. And we want to share a few reflections on what we think about that. We also have asked some questions about how you're treated in the healthcare system. In the conversations that so many of us have around health equity and social justice, and how are we really sort of moving the needle on these kinds of issues, there might be a wake-up call right here in our own backyard in terms of healthcare delivery and how we're treating people even in the medical establishments. Use of healthcare, we're seeing an upswing in many regards, but we do have some notable exceptions. So more people are utilizing certain kinds of healthcare services, and there are certain kinds of healthcare services that aren't being utilized. And then behavioral health is one of those where we still have a lot of need, right? And so we might be doing better in the physical health realm. Behavioral health realm is one where we think there's still work to be done. And then finally, with affordability, we see warning signs that we're sliding backwards, that we're stepping backwards. And I think that this provides sort of a legitimization or sort of providing some credibility to the urgency in which the current administration here in the state is acting with things like reinsurance and public option and the Office for Saving People Money, right? This is an urgent issue and a concern for many, many Coloradans. So before I get there, I wanted to back into just a reminder of what the CHAS is. The CHAS is a nickname that we've developed internally for the Colorado Health Access Survey. We've been doing this survey since 2009. And each year, every other year, we should say, we survey 10,000 households. These households are representative of the population of Colorado, and we make sure that it is through our sampling and weighting methods. We fielded the survey this year between February and June of 2019. We like to do that. We try and get the survey out in the field, and we did this year right after open enrollment closes. Our thinking is that health insurance is top of mind for many consumers during that time frame. And we pride ourselves that the CHAS is this really rich and deep data source. And so we're not only asking, are you uninsured, but why you're uninsured? What are your attitudes towards the healthcare system? How do you feel you've been treated in that system, right? And so we're trying to get a little bit more depth around the questions that we're able to ask and address on this survey. So we had a change this year in the methodology of the survey. So by a show of hands, can you raise your hand if you have picked up a telephone or seen a call from someone who is trying to survey you this year, right? It's a political year, raise those hands high. Somebody try and survey. Keep your hand up if you stayed on the phone to take the survey. All right, a few hands go down. Raise your hand if you would stay on the line for a 22-minute survey about your health insurance practices, behaviors, utilization, right? So there's no hands up. The upshot of what I'm trying to demonstrate is like no one stays on the phone any longer to do these surveys, except for we do okay still with this method with senior citizens. My grandma has lots of time to spend on the survey, right? But by and large, people don't respond to the survey. They hang up on the survey. It's an ineffective and costly method. So we moved to a new sampling methodology called address-based sample. And we sort of a back to the future step in that we send a letter out via the post office Those people are randomly selected here in Colorado. We prompt them with a few postcards and reminders along the way, and we drive them to either call an 800 number or get online and fill out the survey. For those research-oriented people in the audience, and I know who you are actually, you'll be asking me about questions about methods, right? And so like, can you really trend this data if you change your method so significantly? Amy Downs is right here, top of mind question. I'm trying to be anticipatory of this. We did do a small phone sample, enough of a phone sample. We sort of did it the old way to make sure to build the confidence that we could trend using both the old and new methods, right? And so we feel confident. You'll see a few places where we have some questions about this. And I'll give you a Starbucks card if you can identify where they are. How about that? Or buy you a coffee. We have a few places where we're questioning that a little bit, but by and large, we're confident in the fact that we're able to trend, and that's what the sample did for us. So I want to also just acknowledge that the CHAS is a significant undertaking. It takes a lot of resource, it takes a lot of time, takes a lot of money, takes a lot of energy. For the last 6 months or so, we've had about 3 or 4 FTE working full-time on the CHAS to deliver this product to the community. And we couldn't do that without the generosity of the funders that you see listed here, the Colorado Health Foundation and the Colorado Trust. We're also very thankful to the Office of Behavioral Health and the Department of Healthcare Policy and Financing for fielding some of the questions on the survey as well. So if you like the results and you use them a lot, write to one of these funders and let them know how helpful it is in your work. Let's see, before I go any further, does everyone have a phone with a camera on it here? Okay, so could you take that out? All right. So I'd like you to take the next minute and document this moment by taking a photo. The photo is not of me. I do not want anyone taking a photo of me, but I want you to like sort of document this experience in some sort of creative way. It could be like a view outside, or a view of your best friend, or a view of the beautiful manicure you treated yourself to over the weekend. It could be anything that you like. It could be a selfie. Go Dee Dee DePearson. It could be anything you like, but take a minute to document this moment in time. You can huddle. You can be with your best friend. Okay, does everybody have a photo? Okay, so save those photos because we're going to come back to them at the end of this discussion. But my point I want to illustrate is that the CHAS takes a picture in a moment of time. And we can compare that picture in 2019 to a picture that we took in 2017. And I'm going to show you those pictures sort of side by side in the course of this presentation. What we need your minds on is why we see the changes that we see. So I'm going to ask you questions like, where should we dive deeper, where the results look interesting or curious, or we need to know more in order to get to a policy implication? I'm going to ask you, like, what policies do you think played a role in the differences that we've seen in the last 2 or the last 4 or the last 6 years? What have we done here in the state to maybe support some of these changes? And finally, what are we going to do? What does this imply for future policy discussions and decisions? We're really good at providing the 2 snapshots, and we're really good at defining what those differences are, but it's the collective wisdom of everyone in this room that's going to be able to sort of fill out and paint that portrait. So that's our ask over the next few minutes here. So let's dive right in. Coverage, no change on the surface, but still waters run deep. Notice the animation on these layouts, these transition slides. That's the work of the very clever Brian Clark, who is here with us today. So thank you, Brian. He's always making our life pretty fun. So what do we mean by this? So we mean that we saw this dropped in our overall uninsurance rate between 2013 and 2015. What was the big story there? Medicaid expansion, ACA implementation. We sort of held steady in 2017 and we hold steady again in 2019, right? So that's the story. But the undercurrents, the things that are happening underneath that numbers are worth teasing out. So I'm going to spend a little bit of time teasing out those numbers. This is a slide that illustrates how all of us get health insurance in the state of Colorado. These bars, year by year, add up to 100%, right? So the first thing I'm going to point out is these uninsured rates. And so you saw them on the linear representation before. They've gone from a high in 2011 of nearly 16% to our low here at 6.5%. So that's how some of us are not insured. Most of us are insured through our employers, right? And in 2017, the story was less than half of us got health insurance through our employer. And we sort of dipped below that 50% threshold, and we thought that was pretty significant, particularly given that the pre-ACA levels were up near 60%. We've tipped sort of back over 50% in 2019. We can attribute that, I think, to the growing or sort of expanding economy here in Colorado. I heard Elizabeth Gardner not too long ago, their state demographer, give a talk about who's moving into the state. And something like 100,000 people are moving into the state each year. They tend to be college graduates. They're coming for jobs. They come to fill all these apartments that you're wondering who can possibly live in all these apartments. Those are the people who are coming to live there. But when they come with jobs, they also come with health insurance. And so we speculate that that's part of the reason that tipped up above again. The individual, this is our Medicaid numbers right here. Also important for us to take a look at. Medicaid expansion in 2015. As you can see, that's just reflected in the numbers. A lot of people got coverage through Medicaid expansion. We've sort of held on to that. But as many of you know, particularly those who work in Medicaid or in the safety net community, Medicaid enrollment has dipped, particularly in the last 12 months, quite a bit. And some people are surprised that hasn't dipped more on our survey. We're looking into that a little bit, but we think that it has to do with the timing of it. We asked for a retrospective look back over the last year. What's your insurance status over the last year? That may have something to do with it. But Medicaid is dropping just ever so slightly. This is the individual market, which is important for the health insurance exchange and public option and implications along those lines. And Medicare finally filling in here. The senior population is holding steady or growing just a little bit. So that's how we're getting our health insurance. Of course, this is a familiar story. Our insurance, who's insured and who's uninsured really varies by region. So the darker the purple, the higher percentage of population that's uninsured, right? So the darkest purple represents somewhere between 12 and 15% of the population being uninsured. So what's significant about this? Yeah.
I-70 resort corridor and affordable rates.
Yes. Okay, yeah. Good one. So, if you think about the policy discussions and legislative enactments of last year in particular, where did the public option originate? In Summit. Where did reinsurance originate? Summit. Where did Peak Health originate? Summit, right? And so there's some sort of thing happening. They're responding to their constituents. They are responding to the urgency of this affordability issue, or at least we think it's an affordability issue, but at least we know that they're not getting insurance. And so it's those kinds of connections that I think are important as we sort of think through and ruminate about this data. Anything else come to mind on this slide? All right, I'll move us along. We also wanted to look at uninsured rate by age. And there are two really, we thought, we're nerds at CHI, but there are two really exciting things on this slide. So the first is, what have we called this 19 to 29-year-old group in the past? Yeah, Young Invincibles, right? And Young Invincibles sort of led the pack in terms of the highest uninsured rates, and they've been overtaken by the 30 and 40-somethings, right? And so they actually have a lower uninsured rate than the 30 to 40-somethings. Why do we think that might be? They can stay on their parents' insurance. Do you have a kid in college by any chance? I have two. So the kids in college. So one of the ideas that I'm sort of playing with here is that there may be a difference between the passage of the ACA and the actual sort of enactment or the implementation. It may take a while to get the word out to parents that, or to kids that they can stay on their parents' health insurance until they're 26 years old. So it's not so surprising that it gets picked up in the data this year, and then the 30 to 40-year-olds or 30 to 50-year-olds really sort of rule the day in terms of their lack of insurance. The other cautionary tale, I think, is with the children's number. We see this uptick from 2.6, 2.7 last year to 4.3%. We've done a little unpacking of that number, and that becomes even more of a cautionary tale. When we look at that number, and we break it out between the Hispanic population and the non-Hispanic population, the non-Hispanic population, the uninsured rate has actually gone down, and the Hispanic kid population has increased by over threefold, right? So we've had a big setback in terms of insuring kids whose families identify as Hispanic or Latinx. So this is, we think, sort of a red flag for us to really think about. That the 0 to 18 Hispanic cohort is up near 8% uninsured rates. And so there we've seen a sort of a really skyrocketing of that. That's about 55,000 kids that used to have health insurance who no longer do between 2017 and 2019. If we sort of look at the Hispanic population, this has been a population that has historically had among the highest uninsured rates, and that continues to be the case. We see sort of this leveling off at 10%. What I think is important is that that's twice the rate, almost twice the rate of the white population or the non-Hispanic population in our state. The non-Hispanic population is 5.5%. So this is up at 10.2%. So that continues to be, even though it seems like there might be some progress on that, it's still a place where I think there's opportunity for outreach, enrollment, and policy changes. We do ask a question about citizenship on the CHAS. We don't ask a question about documentation status, but we do ask the question, are you a citizen? And this is the breakout of uninsured rate by citizens versus people who are not citizens. In this number here, about 45% of the population in the non-citizen category are Hispanic or Latinx. So it's it's perhaps related information there. And finally, I want to look at our uninsured rate by income status. This is lowest income over to the left, highest income over to the right. And we've stratified this by who's eligible for Medicaid, who's eligible for subsidies and things like CHIP. And then we look at this over here in terms of people who are not eligible for any subsidies at all. Before the ACA was enacted, Medicaid, or that people at or below 100%, and this 100 to 200% had the highest uninsured rates in the state. And that sort of dropped off, right? And so those populations have been absorbed primarily by Medicaid. What hasn't dropped off and what leads the pack this year is this 200 to 300% of people we are reporting the highest rates of being uninsured, over 1 in 10 people in that category. Why do we think that might be?
Because they don't qualify for public and they don't have ESI. So they're
Right.
going through the exchange.
Yep, exactly. And so we think this is a really price-sensitive population. There's the cliff effect where they don't qualify anymore for Medicaid, and it seems like a hardship to pay even the subsidy of their on their health insurance premium. So that's something to watch, and I think there's been a lot of policy attention in that particular area around these transitions. Another sort of area that we really want to explore, and we think it's sort of a bellwether and maybe a hallmark of things like market instability, is this idea of churn. So we ask people, have they moved off of health insurance within the last 12 months? Have you lost it? Have you gained it? Have you moved? Have you switched? And what we see here is that number is steadily rising, right? In 2013, it was 12%, 15%, 17%. Now it's 1 in 5 people. This is the non-Medicare population, because when you turn 65 and get on Medicare, you tend to stay on Medicare. But of the under 65 population, 1 in 5 of us is reporting that you do some kind of turning or churning in the last 12 months. So this is one of those, is it a half glass full or a half glass empty kind of scenarios, right? So it might be, there might be some, one of the purposes of the Connect for Colorado is to provide choice for people, right, on the exchange. And so you will look every year, figure out which product works best for you, meets your affordability needs, and churn. But we also think there's probably other storylines going on here as well. There might be issues of, it certainly can play out, more than half the people, when asked why they've churned, say they lost their employer's coverage. So why they're not being picked up someplace else is an avenue that we really want to pursue. And of course, the implications for this are really about continuity of care, making sure that people stay in the system, get the primary care and preventive care that they need. Questions or comments on churn? All right. So I'm going to move from our uninsured rate to some newer aspects of the CHAS. And we've asked a number of questions this year about the issues in the sort of social determinants or adjacent health spaces. And these really point to the fact that the boom that we're seeing, this economic expansion, is not universally shared, probably not news to all of you in this room. 18% of us report having trouble paying our medical bills. Another 10% of us have reported food insecurity over the last 12 months, and another 7% of us have reported some housing instability within the last 2 months, I think the question is, right? And so these are indications that it's not a perfect world for everyone here, and these are certainly indications of that. We did a deep dive into looking into this specific question about respondents who ever ate less than they felt they should because there wasn't enough money for food in 2019. The darker the purple, the more people answered this question. The dark purple indicates that somewhere between 14 and nearly 20% of people in those areas said that they forsake food because of lack of access to money. Offer a reflection on this slide. Dee Dee.
Yeah, just people, I mean, we said this a long time ago, people are trading off what they can afford to pay, right? They
Right.
pay rent, or they pay health insurance, or they pay car payment or childcare.
Right.
And food is one you can skip on, it's also a place you can go to food pantries for.
Right, right. Anything else? People in the last session noticed that it seems to be the worst problem in the more agricultural districts of our state, right? And so, like, what's sort of happening there? There's also some questions about the urban-rural split between this, because a lot of these areas where the problem seems most acute are in rural areas of the state. And rural areas have, among their population, a disproportionate percent of people living under the poverty level. So if you look at the poverty line in rural areas of the state, about 24% of people live under the poverty line, and in urban areas that tends to be well under 20%, at 17.5%, right? And so you're dealing with very different populations, and I think it's reflected in this screen here. We asked questions this year about, for the first time, about if you've been treated fairly when you get medical care. And we asked the question of Colorado adults. This is the results of Colorado adults who report being treated unfairly when getting medical care. So 60% of us report that they never have been treated unfairly, but that leaves 40% of us who have at some point or frequently or with some frequency are being treated unfairly by the system. Yeah?
Does that refer to the care I get, the way I'm treated when I go to the doctor's office for my appointment and my experience receiving health care, or does it include things like I can't afford to pay my bill and nobody's telling me about financial assistance, or the billing people are horrible or nice, or, I mean, what's unfair?
Right. So we leave that up to the definition. Sort of beauty is in the eye of the beholder, and so this is the question that we ask of respondents, and so they're free to interpret that in a way, the way that they want to. We do ask specifically about when getting medical care, trying to hone in on what the experience is in the medical setting. So that's a way that we've tried to refine that question a little bit, but the issue with self-reported data in this question and others is always that, like, sort of, yeah.
So that would capture people that actually, because of the way they were treated, didn't access care.
Correct. So, yeah, when getting medical care, right? So you're right, there's probably people who have opted out of it completely, right? Yeah.
Do you ask over a certain time frame, or is it like ever in your life?
This is ever in your life. No, this is within the last 12 years, because our national comparisons are to, we're trying to find some national comparisons to this question, and we've seen that over the course of your life. Is that right? Do I have that backwards? Becca?
I think it's lifetime.
It's lifetime, okay. So, lifetime, sorry. My lifelines, Jasmine Baines and Rebecca Silvernail in the back. So, over the course of your lifetime. So the reasons that pop up, any guesses on why people most often report being treated unfairly? What did they say?
Potentially because I'm on Medicaid, and so I'm treated differently than someone who might have private insurance.
Right. One of the reasons. Others that come up? Yeah.
Sexual, I don't know what the PC word for it is, but like sexual identity.
Yes. Yep, number 2 on the list. So gender, issues related to gender come up number 2 on the list. Number 1 on the list?
English proficiency?
Yeah, no. It's my gray hair, it's our age. Age comes up as the number 1 reason that people are treated unfairly. age, gender, and disability are what's reported out on the CHAS. And so all of these are reasons that people feel that they're treated unfairly. We're going to do more work into that, but that's our preliminary analysis. So I want to switch over and take a look at utilization of care and how that's changed between 2017 and 2019. And we have some interesting findings here. First of all, we've seen an uptick in people visiting the doctor, of going to the dentist. And I want to point out that, that these bars may not sort of illustrate the significance of this because of the scale on the y-axis. We've seen a 70 to 81% jump, or a 10% jump in the number of people who said they went to the doctor from 2017 to 2019. That represents over 550,000 people who said that they increased their utilization of going to a doctor, and the same thing for about half of that for dental visits. We also think that this is interesting over here in terms of an uptick that we've seen in mental health utilization. So you've either consulted about mental health with your general doctor, going from 16 to 18%. Again, don't let the percentages mislead you. That's about 110,000 more people who did that. And the same thing that they actually saw a mental health provider, right? We saw another sort of 2%, no, maybe 1.5% increase there. So that's a significant number of people. What have we been working on as a state in terms of our big policy initiatives over the last 5 years?
Reducing stigma.
Reducing stigma. What else? What do we get $65 million to do? What? Integrated care, right? And so this, is this potentially an impact of SIM, the State Innovation Model, and our attempts either in SIM or the Comprehensive Primary Care Initiative or a whole lot of other initiatives that are going on to integrate physical and behavioral health. That may contribute to the changes that we're seeing here. Remember this, though, we're seeing an increase in utilization of mental health, and reconcile that for me with something that's happening in the behavioral health world. And that is, our next finding is that we've seen this increase in people who said, I have need for mental health services but didn't get them. And we've seen this dramatic increase between 2017 and 2019. We're doing some additional research on this in terms of, can some of this be explained by methods? We have some preliminary insights that people are a little bit more uninhibited to share their mental health needs when they're filling out a survey online and not talking to a person on the phone, right? And so this might be a little bit of a distortion. We're going back and sort of trying to figure out what that means. But assuming that there's this uptick, how can we have more people getting mental health services and more people reporting that they need them but didn't get them?
I just think with our nurse family partnership population, which is just first-time moms,
Yeah.
what we find is the awareness that increasing, the stigma decreasing as a consequence of the relationship that they have with that nurse and the message that they're getting, but their inability to access appropriate care. So they may be able to find a white male therapist, but they can't find a woman who looks like them.
Okay.
So the inability to, the access issue, but not just access, but access to somebody who they feel like they can have a successful therapeutic relationship with is very limited.
Okay.
And we're in all 64 counties.
Right.
So it depends on where in the state you are that even the white male therapist exists.
Yeah.
So I think there's a lot more awareness and a decrease in stigma with our population, given all the mental health initiatives we've been focused on, but that access remains a huge barrier.
Okay, and particularly the sort of culturally relevant or access.
Yeah.
Okay.
Exactly.
Yeah, Dee Dee.
It's been a pretty significant, I think, based on what I know, decrease in private mental health or behavioral health providers sort of willing to accept any kind of insurance, particularly private insurance.
Okay.
So even though you theoretically have coverage, there's nobody who is actually will take your insurance.
Yes.
It's kind of like being Medicaid.
Right, so even though there's parity laws on the books, you still can't find someone to take you, okay? Anything, yeah?
There's also an increase in the number of dual diagnoses happening, but then a lack of providers who can actually treat both mental health and substance use issues that that person might have. So they don't have to go to 2 or 3 different providers to get that sort of treatment. They want someone who can treat everything at once, and there's just a lack of providers who have that specialty.
Interesting, so we need to have like sort of consolidated services, you think? Yeah, great. So that's another area where we're interested in doing more. When we go back to the substance use disorder, reporting 2.3% of the population said, I needed substance use disorder treatment and I didn't get it. That 2.3% seems like a small number, but it's actually quite a significant number. It's equivalent to 95,000 people, which is equivalent to the city of Longmont, right? So imagine the city of Longmont where every single resident has reported that they need access to substance use disorder treatment. It's just a visual to understand the impact or the magnitude of the challenge that we have. We ask people, this is sort of a deeper dive into if you haven't gotten mental health services, why is that the case? Why didn't you receive them? And I point to the top line and the bottom line because both of those are the highest percentage of people reporting that, and they both have to do with cost, right? And so this mandate around, for the Office of Saving People Money on Healthcare, the mandate around affordability, this is in response to this kind of need for more affordable care. And then the other thing that I would point you to is the second and third lines here about you didn't feel comfortable about you didn't feel comfortable talking about personal problems, or you're concerned about having someone find out. I think that's to your point around stigma. So even though we're raising awareness and doing more in terms of public education, we still, what my read into this is we have a ways to go in terms of really reducing stigma in a meaningful way. We ask the same questions on substance use disorder and similar kinds of things, except the stigma questions or the stigma reasons are really pronounced, right? So 73% of people say, I don't want people to know about my substance use disorder. So again, cautions for us in the policy community. For the first time this year, we asked the question, have you or a loved one or a close friend ever, and the first line here, has been addicted to prescription painkillers or heroin? And 12% of us say that, yes, that's me in some way. Been addicted to alcohol or drugs other than prescription painkillers or heroin. And 1 in 4 of us know or have lived that experience in one way or the other. And I think about this, sometimes, I think there's some interesting things here about sort of tipping points in political movements or social justice movements. So some of the literature on gay rights and gay marriage, that there was a profound change in this sort of social justice milieu around that, when people realized that they had a brother, they had a sister, they had a friend, they had a cousin, and that a lot of people see that as sort of a tipping point in the gay rights movement. Perhaps this is a tipping point as well in the substance use disorder movement, and we might want to ask the question of what number does that need to be at to have that sort of rise in our social consciousness? That's about as philosophical as I'll get today. Dee Dee.
I think it's not just the number, but it's who.
Yeah.
Right, when it hits white middle class or white upper class,
Yeah.
it tends to get more attention, so it's not just the percentage, but where the problem sits.
Yeah. Good point. Anything else? So, and to that point, we ask this question of people to say, is opioid addiction a major, minor, or insignificant problem within your community? The darker the purple, the higher the greater the percent of people saying it's a major problem. So this is illustrating people who think this is a major problem. The darkest purple represents 33 to 54% of people say, yeah, this is a major problem in my community. The most surprising, and Dee Dee, maybe this is related to your point, the most surprising part of this question is what's not here on the slide. 50% of the respondents to the survey said they didn't know if it was a problem or not in their community, right? 50%. And if you're like me, you kind of live in a world where it's opioids and painkillers and painkillers and opioids, and what are we doing in crisis and epidemics? And we have 50% of our fellow Coloradans who don't know, right? And so what does that mean for us? And what do we want to do about that, I think, are legitimate questions to pose.
Was there any sort of definition on what a community is? Like, is it your neighborhood? Is it your state? Is it...
No, but...
It's not in my neighborhood, but I think I think of my community as Colorado. I think it's a huge issue.
Right, right. So I don't think we did anything on the survey. We just had, it's one of these self-perception issues. We got the flip side of that in terms of what constitutes a major problem. Did you define that by, and so those things are left to interpretation. And finally, I want to talk a little bit about affordability, and what we see is sort of a problem in terms of backsliding here a little bit, and sort of a creation of urgency around the action that I think a lot of us are involved in undertaking. You've seen before that 18% of us said that we've had trouble paying a medical bill, and we also have, when we ask people globally, everyone who's uninsured, why you're uninsured, it all boils down to cost, right? And so these are marching orders for us as a state, which I think we're addressing in a lot of ways. And finally, this idea of surprise billing. 1 in 3 of us here in Colorado report that we had a surprise medical bill in the last 12 months. Are people surprised by that, or totally not surprised? Not surprised? Right. So this is, again, there's a lot of policy efforts around surprise medical billing. This is probably one of the reasons why, or the most pressing reason. So those are the 6 stories that I wanted to share with you here today. Don't be fooled by this sort of steady state of the uninsured. We think that access is still a problem, and it's a particular problem for some populations more than others. Housing, food, and health point to the fact that there are still really vulnerable and marginalized populations among us. I think we have a wake-up call in the conversations that we have about health equity, social justice, what's happening in sort of our own backyard of healthcare and medical care. What do we need to do about that? I think we need to think about what's proper utilization. If we see an upswing in utilization, is that good? Is that not so good? Are we seeing a distinction between preventive and primary care visits or specialist visits? We think we need to unpack that a little bit more. Behavioral health is sort of a complex and puzzling. We need to put our puzzlers on it even more than we are now, because we're seeing an increase in demand for those services. We know anecdotally and from the other work that we're doing in behavioral health that capacity is a big issue. Finding proper care, finding culturally relevant care, all of those things come into play in terms of behavioral health. And there is a reason why we're addressing so aggressively and so progressively this idea of affordability in the current agenda today. So I'm going to ask you to take out your phones again and find the photo that you took. And tweet that photo to hashtag, Amy, you know how to tweet. Joe can help you, your former colleague. Hashtag Chaz19. And you can do one of 2 things. You can offer a reflection that would be really helpful to us, Or you can wish the Chaz team a happy 10th birthday because that's what we're celebrating this year. Chaz 19. Did you do it, Amy? Yes. Proper professional etiquette. All right. If you're dying to learn even more about the Chaz and the insightful findings from the Colorado Health Institute, I encourage you to sign up today for the Hot Issues in Health Conference, December 5th and 6th. Our closing session this year is by our friend, colleague, beloved CHI character, Jeff Bontrager, who's the primary investigator on the Chaz. He promises to be funny, witty, insightful, and share all of even more nuance and even more details with you about the Chaz at that event. So mark your calendars and join us on December 6th. With that, I thank you for your time and attention, and I am happy to take questions, comments, reflections.
Do you, is one of the things that you have, well, two things. One is your presentation today or the report itself on your website?
It is.
Okay. And secondly, is there information in there that breaks down, and I don't know if this was one of the questions, well, maybe you already showed that, I'm sorry. What percentage of the total respondents were private insurance, Medicaid, Medicare? Was that?
Yep, it's on there. It's one of the early slides.
Thanks.
Okay, great. Anything else? Dee Dee?
Just think moving forward and thinking of the work we've been doing since 2017, and thinking about the next Chaz, or maybe if there's any way to parse this in this one, the impact of federal policy and public rhetoric that is
Yes.
anti-immigrant on Medicaid enrollment and CHIP enrollment.
Right.
If there's any way to parse that out of it.
Yeah, we've been sort of exploring that question because we think that the spike in the uninsured around the Hispanic and Latinx kids has a lot to do, not necessarily with the public charge because that doesn't add Medicaid until October 15th, but the heightened fear around the public charge. And we've talked to our colleagues in the safety net community who have affirmed that people aren't seeking care, are not re-enrolling in Medicaid. They don't want to, anything that looks and feels like a government kind of, government initiated anything is they're not going to do. So I think we can get to some speculation about that. We have written on the public charge and we have estimated that 75,000 Coloradans would drop their health insurance coverage. And that's based upon the uptake, the impact of other sort of changes to public charge over the years. But I think that's a really critical point. I mean, it's this, how do you parse all of that out?
And it gets to that other question I asked about people that actually don't get access to medical care because of how they're treated.
Right, yeah.
It's that first interaction, they don't get past it.
Yeah, I wonder if we can take a look at that in some way. Good things to think about.
You should, if you are able to figure out a survey for your FQHCs.
Yeah,
They've seen it. The ones in our region have seen it.
Yeah.
And it's that I don't even want to bring my child in for immunizations or well child checks for fear that someone's going to grab me while I'm bringing my child in.
Yeah.
And take me. So it's, even though the children are covered, the parents don't even want to risk bringing the kids.
exactly. So, all right, well, I thank you very much for your time and attention. Go enjoy the sunshine.